good evening, everybody. I want to thank everybody for taking time to be here with us this evening. And I want to start with a quote. Your job is not to judge. Your job is not to figure out if someone deserves something. Your job is to lift the fallen, to restore the broken, and to heal the hurting. It's Joel Osteen. And I think that when we're coming together tonight, we have a community like so many other communities that's struggling with the opioid epidemic. And I think the good news is that this is another step of a community coming together and to have a discussion about what we can do to learn from people that are really cutting edge and really leading the way on this opioid epidemic. And also to let people know what we're already doing and to also look out to all of you to continue to participate in turning the tide in our community. This problem will only improve if we continue to dedicate and commit all of our resources across multi-sectors. It can't just be from the medical profession, it can't be through city government, it can't just be through the police department and all the organizations that are working on this problem. It has to come from beyond that. And I'm very excited about the work that we've been able to do so far this year, certainly with the New Bedford Opioid Task Force. I'm very grateful for the Nurses to Prevent Opioid Abuse, which that group has been strong over the last year, and also my brothers and sisters as physicians that have come together for the Physicians to Prevent Opioid Abuse with a commitment to really work hard and to get our hands dirty and try to help people. So I'm going to give Mayor John Mitchell, who's come to join us this evening, the opportunity to say a few words, to lead us off in our discussion tonight. And then I'll come back and I'll introduce our speakers. Just to also spend a couple of minutes, I'd like to also thank all of our event partners. Our fiscal sponsors tonight are the Carney Family Foundation, and they have been incredible with their support for various important issues in our community, and certainly the opioid crisis being one of them. And I really thank you for all your support and efforts to really help our community. The City of New Bedford is partnering today. South Coast Health Systems is partnered certainly with CME credits for the doctors and nurses this evening. Physicians to Prevent Opioid Abuse, Nurses to Prevent Opioid Abuse, the Greater New Bedford Opioid Task Force, and we want to also thank for the partnership with the New Bedford Whaling Museum, who's given us the opportunity to use this beautiful room. So without further ado, I'd like to turn this over to Mayor John Mitchell to say a few words. And again, thank you for everybody being here tonight.
All right. Well, thank you, everybody. And thank you for coming here tonight. It's, the turnout is very heartening. I just literally just got back from the U.S. Conference of Mayors winter meeting, and I can tell you, there are a number of things to report back, but if there's any one thing that stood out over the last few days is that the opiate crisis, and by crisis I do mean crisis, it is the appropriate way to label it, is the most vexing public health problem in America today. There's been a lot of discussion around this, and especially as you would think among mayors, where it's at the city level where the problem rears itself, although it is a rural problem as well in certain places, but it is also the place in city government where folks are convened, through which folks are convened to deal with it. And as Dr. Rocha noted, it isn't just a matter of government action is a pathway toward a solution, although that is necessary. And it rather is a problem that is so multidimensional, so unwieldy, that everybody's got to get involved. And so your appearance today is, as I said, encouraging in the sense that I think by your being here, you recognize that we all have to step up. mayors across the country are experiencing, cities across the country are experiencing the opiate crisis in many ways. I talked to the mayor of Nan Whaley, who's the mayor of Dayton, Ohio, where folks have, or countless folks have died from opiate addiction, from opiate overdoses in the last few years. She just sued, filed a lawsuit against a number of pharmaceutical companies as a way of not just addressing one part of the problem. In Ohio has not passed legislation like that, which passed in Massachusetts a couple of years ago, that puts some legal restrictions on opiate prescriptions, and so she took matters into her own hands. I've talked to mayors in places like Nashua, New Hampshire, and Louisville, and lots of other places, and including in states that aren't known at this point for being the ground zero in the opiate crisis, and it is still a big problem. And what emerges, I think, from the discussions more than anything else is what Mike hinted at, which is that there isn't a silver bullet. There isn't a silver bullet, and the solutions will take time because we have a very large population of folks who are addicted. We have many other folks who are prone to addiction, and we have a growing and ever cheaper supply of heroin in our city streets and in our rural counties, and I'm speaking across America. Here in New Bedford, we've seen a jump in opiate deaths. Even though we were one of the first communities in the state to arm all of our first responders with Narcan, we saw in 2015, we saw 46 opiate deaths in 2015, in 2016, 55. Now, mind you, this isn't a city that has, through the great efforts of our police department, and Joe Cordero, our chief, is here, have significantly reduced gun violence. We had 3 homicides in 2016, which is very low for a city of our size and demographic composition. I mean, compare us, for instance, to Boston, which had 46 homicides in the same year. So we've done a good job with that overall, but 55 deaths from opiate overdoses. I mean, it's significant, it's hugely significant, and it feels at times, despite the best efforts of lots of folks, that we're not stemming that tide. We are doing a lot. You see the icon of the Great New Bedford Opioid Task Force, which is a group comprised of many folks in this room, not just city government and the police department in particular, and the health department in particular, and community services, but places like Seven Hills and PACA and South Coast Health, all the healthcare providers, the community health center, many others, too many to ask. They've been at it for a while, and what's emerged is a set of practices that I like to think are gaining some traction, although not one of which is a solution unto itself. These include clergy ride-alongs, something that David Lima from the Interchurch Council has spearheaded, where clergy and plainclothes police officers go out to houses known to be either occupied by the family members or by addicts themselves to intervene directly, almost in sort of grassroots campaign style fashion, going directly to the problem rather than reacting to it, trying to get people into services, knowing that the window of opportunity to get folks into treatment, whatever treatment it is narrow and closes pretty quickly. And so the effort there is one to just get in the face of folks who might need that attention. It's stuff like the drop-in centers that we just announced last week, that, again, working with the faith community in our city, that we believe will be another way of reaching people who need to be reached. It's things like the efforts in the law enforcement end to stem the tide of the growing tide of fentanyl, which is becoming which is really starting to swamp many cities around the United States, and we see more and more of it all of the time as more folks, not just in China, not just in Mexico, but folks even here in the United States are figuring out how to make. It turns out that you don't have to be that great at chemistry. You don't have to be a Walter White to actually produce this stuff. So we're seeing more of that, and I think there are some efforts, including at the state legislative level, that need to be kicked into gear to deal more forcefully with interdicting fentanyl and penalizing dealers, because that is part of the solution. We also know that the best way to prevent addiction or the best way to deal with addiction is to get people who, is to make sure, to do whatever we can to make sure that people never get addicted in the first place. And that includes the efforts in our school system, which have been beefed up in the last year to sensitize children as young as 4th and 5th grade that opiate addiction is real. It happens to folks in every corner of our community, regardless of race, regardless of economic circumstances, and that everybody has to take it very seriously. About 2 or 3 months ago, I remember my 5th grader coming home from school and talking to me about drugs and about how big of a problem drugs are and how perilous it is for folks to even to try them, and which is what I was surprised in the moment that she said it, but I sat back and I thought, good thing, it's sinking in, and I hope it sinks into the minds of every child in our community. And then there are the efforts at, of course, treatment, which runs the gamut, which many of you folks in the room are dealing with as well. The efforts of the physician community in combating this is instrumental. It is necessary. It is vital. None of it will work without the input and without the close cooperation of our medical professionals. And therein lies your role. You see it all the time. You hear the stories about activity in the emergency room, but also the effects of families that you see coming to the emergency room, the folks who are showing up just for inpatient appointments and seeing the effects that addiction has had on them, even just in a passing way. It's a reality that's not lost on any of you. I guess I'm here today to say thank you for being part of this. The great view and the good food are wonderful. Nice night out in the summer in New Bedford is always a nice thing. But this is work. It's a work, and it's going to be work for a long time. And I think we have to resign ourselves to that. I mean, it is a big problem. Big problems take big effort. They take teamwork. They take determination. We can do this. Of course, New Bedford's not alone, and New Bedford can't tackle a national problem on its own. But what I'd like to see here, as much as anything, is that from this very talented group and the rest of the group that's out there working on this problem here in New Bedford, that we can be an example for everybody else. To do that effectively, we of course need to be open to new ideas, again, because not one of our efforts standing alone is going to solve it all. And so the more that we can import the best practices, the brightest ideas, the ones that are most effective, and do it effectively, implement them as seamlessly as we can, the better off we'll all be. And so I really want to thank all of you for being here today. You're going to hear from both Drs. Wakeman and Kane in a few minutes. I really wanted to thank you for your efforts and your participation here. It is very helpful for us to get on top of things through the input of folks from other cities who are experiencing the same set of problems. And of course, I want to thank Pat and Will Carney and the Carney Foundation for being the prime movers in this event. I mean, this is, I know we've worked with folks like Mike, Craig Longo, and so many other physicians who are spearheading efforts, and you've really come to the support of those folks who are doing amazing work in our community and whose work is far from over, as we know. And so really in the best tradition of foundations that really give back to their communities, the Carney Foundation has really stepped up. So I want to thank you both for making that happen, and I really appreciate your leadership. So with all that, yes, please. So let me just close by saying this, and again, at the risk of redundancy, this is a massive problem, but we have the talent, we have the commitment, we have the determination to make the right changes here so that we protect, that we can save lives, that we can protect families and make our community a stronger place. So I want to thank everybody for pitching in tonight and spending your precious time on a nice summer night to figure out what more we can be doing. So thank you very much, everybody.
So I'd like to take a moment just to introduce Dr. Sarah Wakeman. She's currently the director for the MGH Substance Use Disorder Initiative. She's the program director of the MGH Addiction Medicine Fellowship and an assistant professor of medicine at Harvard Medical School. Her special areas of knowledge and research include evaluating models for integrated substance use disorder treatment in the medical setting, recovery coaching, physician attitudes and preparedness related to substance use disorder, and screening for substance use in primary care. She also previously served on Governor Baker's opioid working group, and she's really, I think, one of the leaders in our country for doing this work. She's been very outspoken about making the appropriate changes and advocating for patients not only in the greater Boston area, but for what needs to happen throughout the country. So we're very excited to hear from her and learn more about what she has to teach us tonight.
All right, thank you so much for that warm welcome, and great to be here. And I know I stand between you and your dinner break, so I speak quickly. I won't. I'll try to review a lot in not too much time. And I really want to focus today on the role for healthcare providers, so physicians, but really all types of healthcare providers. And I think if there's any message in providing treatment and care for people suffering from substance use disorder, it's that it takes a team or a village. And that team includes families and community members, but it also includes all members of the healthcare team. And so I'll really focus on that today. I have no disclosures. So I have 3 objectives in the time we have together. So first, to understand opioid use disorder as a chronic illness, much like many others we see in medicine all the time. To describe what effective treatment for opioid use disorder looks like. And then to review an example of the healthcare system's response to the opioid crisis by telling you just briefly about what we've been doing at Mass General. And then my close colleague, Dr. Kane, who I think is probably stuck in Boston traffic, will take over and tell you a little bit more about one particular component that we're really excited about, which are recovery coaches in our initiative. So I think you guys all know why we're here tonight. Drug overdose is actually now the leading cause of death for Americans under age 50. So you can see we've now surpassed the peak of HIV deaths during the HIV and AIDS epidemic, the peak of gun violence deaths, and the peak of motor vehicle accident deaths. So this is truly a crisis of opioid-related death. And we often focus on the deaths, and obviously those are the fundamental thing we want to prevent. But for every person that dies, at least 2 times as many people are hospitalized, 4 times as many people show up in our emergency rooms just for non-fatal overdoses. And that doesn't even begin to touch the many medical consequences of untreated opioid addiction. The infections people can get related to injection drug use, and the many other types of consequences they can experience in their medical and their mental health. You can see here that the rate of emergency room visits and hospital-related visits has increased dramatically, and MGH, Massachusetts, actually has the #1 highest rate of emergency room visits for opioid-related causes, and I'm sure that's something that touches you here in the EDs in New Bedford as well. And this has been so dramatic that it's actually changed the mortality curve of non-Hispanic white Americans over the 21st century. So this was a seminal paper that was published by Case and Deaton that looked at mortality rates of ethnic groups in America and then across other countries like France, Germany, the UK, Canada, and Australia. You can see that as medicine has gotten better, as we would hope, mortality rates have decreased. And yet for white Americans, mortality rates have actually increased. And so 500,000 people have now died from the opioid crisis, which again is more than the toll of HIV/AIDS on America. So this has dramatically affected all of us across this country. And these deaths have been called the deaths of despair because it's not just overdose-related deaths, it's also suicides and liver disease-related deaths, which are often due to complications of untreated addiction. And we talk a lot about opioids. I want to remind everyone not to forget about other types of substance use disorder. So alcohol use disorder still kills far more people than opioid use disorder, tobacco use disorder, and smoking-related deaths. So we're focusing on opioids right now, which is important. We're in the midst of a crisis, but really all types of substance use disorder impact people in our communities and our families. And as a physician, as a scientist, I really want to focus on the science when we think about addressing the opioid crisis. For people who read the New England Journal of Medicine, this is a phenomenal report that came out a couple weeks ago by Dr. Nora Volkow and Francis Collins. So they're the heads of NIDA and NIH, which are federal agencies of health and of drug use. And they have this quote that, as we have seen repeatedly in the history of medicine, science is one of the strongest allies in resolving public health crises. Ending the opioid epidemic will not be any different. And so I really want to focus tonight on what the science shows, because the difference between this crisis and many others that we've faced in public health is that in past crises, like HIV, we really had to wait for the science to catch up. We didn't really know what to do. And the funny thing with the opioid crisis and with addiction in general is we actually have 50 plus years of science on what works and on how to address this illness. And it's really the translation gap. How do we get that science to actually reflect the experience that our patients encounter and our families encounter, our loved ones encounter when they're trying to access care? And so in some ways, that's a daunting thing to do, but it's actually much easier than trying to come up with new discoveries and new science. So it's about that translation of science into practice that's so crucial. But before we talk about what works, I think it's important first to turn to what is addiction, and we all come from different levels of experience. So just to start at a very fundamental level, I think personal narrative is one of the most powerful lenses through which to understand addiction. And this is an old quote actually from 1953 from William Burroughs' pseudo-memoir about his own struggles with heroin addiction. And I chose it because he really wrestles with the question that I think we still struggle with, the sort of why does this happen to some people and not other people? And in fact, it's amazing that everyone doesn't develop addiction because we're all exposed to highly addictive substances for the most part, and yet only a subset of people have the vulnerability that put them at risk for developing a substance use disorder. And as Burroughs points out, no one chooses this fate. So no little kid says, when I grow up, I want to be addicted to heroin and I want to suffer from overdoses and get hepatitis C and go to prison and lose my housing. You know, that's not a choice that anyone would make for themselves. And yet 80% of Americans choose to experiment with drugs or alcohol. And so for some subset of those people, they're going to have the unfortunate combination of genetic risk and environmental exposure that will put them at risk of developing addiction. And so you hear Burroughs describe that he tried drugs out of curiosity and sort of drifted along using, which is something we often hear from people. And then he woke up one morning sick. And this is something I hear from my patients, that they actually had no idea that they developed a physical tolerance or dependence on opioids, and the first time they experience withdrawal, they think they have the flu. And it's only after realizing that they're sick that they realize something has changed. And what Burroughs describes is what we now know is the natural history of opioid use disorder, where early on people use opioids to feel good. And that sounds sort of simple, but it's actually important to remember that drugs make people feel good, that people wouldn't use drugs if there wasn't some positive thing that they got out of it. And actually, opioids don't make everyone feel good. Some people feel nauseous or itchy when they take an opioid, and those people are actually probably protected from developing an opioid use disorder. But what we see happen actually relatively rapidly with opioid use disorder in someone who's vulnerable is this shift from using to feel good to needing to use just to feel normal, and then needing to use just to keep from feeling sick. And so if you talk to someone who's been using for a while, they're not necessarily feeling great or having fun. They literally don't feel normal, can't function, can't go to work, can't have relationships, can't do anything unless they have the drug in their system, and they get trapped in this terrible cycle. And so put another way, when you can stop, so early on before addiction is developed, you don't necessarily want to because you haven't started experiencing negative consequences from your substance use. And then when you want to stop, when all this bad stuff starts happening to you, you can't because something has changed and your brain has changed, which we'll talk more about. And so we now understand addiction as a disease of gene environment development. So first of all, this is a developmental disease that for most people has its onset in late adolescence or the early 20s. And it's about 50 to 60% genetic, so it's as genetic as diabetes or heart disease, meaning any one person's vulnerability is based tremendously on the genes that they're born with. But the genes aren't the whole story. So the other 50% is based on environment or exposure. So we think about things like adverse childhood experiences, having a co-occurring psychiatric illness, being around peers who use drugs, trying drugs at a young age. And then obviously you have to actually experiment with drugs or alcohol to develop addiction. And using drugs or alcohol, particularly in someone who's vulnerable, actually changed the structure and function of the brain. And so it's that confluence of events that leads to this behavioral syndrome that we recognize as addiction. And so addiction is defined as a primary chronic brain disease that's characterized by compulsive drug use despite harm. And there's a couple important points in there. So first, this is for most people a chronic illness, meaning the goal is not cure, the goal is treatment and remission and minimizing relapses. And it's fundamentally characterized by doing something that's irrational. And I think that's the thing that's so hard for people who themselves struggle with a substance use disorder or love someone with a substance use disorder or care for someone with a substance use disorder, because it's very easy to look at someone who's in the throes of addiction and to think, why can't you just stop? Like, why don't you look at these terrible things that are happening to your life and just decide to not do this anymore? And yet we know that addiction is defined by literally the hallmark of the illness is compulsive drug use despite negative things happening because of your drug use in your life. And so that's the thing that's so challenging with substance use disorder or addiction is that literally the parts of our brain that control choice and reward and motivation and thinking about risk and benefit and consequences get damaged by the disease. And so fundamentally asking someone who's in the throes of active addiction to just stop would be like asking someone who just had a stroke to just move their right arm. If the part of your brain that controls that action has been injured, you can't willfully choose to do that thing. We mentioned that this is, for most people, a chronic illness, meaning that relapse can and often does happen and really is a sign that treatment needs to be changed, not that there's any failure on the part of the individual, and that it's highly genetic. And we can actually see now that substance use disorder is a chronic illness that changes both biology and function, much like other chronic diseases. So if you think of heart disease on the left, you can see we can use functional imaging to look at heart muscle and see in healthy, normal heart muscle, you can see the rainbow color of kind of normal metabolism, meaning all of the muscle is functioning in a healthy manner. And you can see next to it a diseased heart. So that's a heart where someone has had a heart attack, and there's an area of scar in the muscle. And so that part of the heart is literally not functioning anymore, and that leads to the chronic disease of congestive heart failure. And we actually can see a similar thing using functional imaging to look at the brain of someone who's struggling with addiction. So you can see in the healthy brain, the top part of the brain, which are our frontal lobes, and that's the part of the brain that, again, thinks about consequences. It sort of puts the brakes on the urges that we all have to do things that lead to immediate gratification. And you can see that that's one of the most active parts of the brain. And next to it, the brain of someone who's struggling with active substance use disorder. And you can see that that part of the brain is literally no longer lighting up. And so again, asking that person to just choose to stop, literally the part of their brain that controls that ability to put the brakes on those urges has been damaged by their active disease. The great news with addiction is, unlike a stroke or a heart attack, we actually see those changes get better. But it takes time. So this is a study, again, by Nora Volkow, who's the head of NIDA, that looked at methamphetamine use disorder. And in this study, it took 14 months of treatment and recovery before someone's brain began looking healthy and normal again. And the brain in the middle that actually looks so damaged is the brain of someone who's been sober for 1 month. So if you think about our treatment systems, where you're lucky if you get a few days or a few weeks of treatment, and often a month is considered a long time to be in treatment, we're literally sending people back to the situations that made them sick in the first place before they've had the chance to heal. And that it's only with long-term ongoing chronic care management that people can begin to truly get well. But if we start thinking about addiction as a chronic illness, much like other chronic illnesses, the results are actually quite optimistic. So the treatment outcomes for addiction are as good as they are for any other chronic disease. It's just that we've been expecting these fast fixes or these cures, when really this is a chronic illness that requires long-term ongoing treatment and management. If we think about blood pressure, we would expect that someone's blood pressure would be high before they start treatment, that the majority of people would respond to medication treatment, and that if you stop treatment, people will have a rebound or a relapse in their blood pressure. If we think of addiction within the same lens of a chronic illness, we actually see the same percentages in terms of treatment outcomes. So before treatment, people's addiction is severe. With good treatment, about 60% of people will be in remission at 1 year. And if you stop treatment, a certain percentage of those will have a relapse. So again, the outcomes are as good as other chronic illness. It's just that we've approached it from this inappropriate sort of acute framework. So what is effective treatment? Well, for opioid use disorder in particular, effective treatment is much like what we think of effective treatment for diabetes or for other chronic illnesses. It generally involves pharmacotherapy or medication treatment, psychosocial or behavioral interventions, meaning different types of psychotherapies, and then ongoing recovery supports in the community, including peer support or recovery coaches or recovery centers, and you'll hear more about recovery coaches. That's not to say that everyone needs all three of these. Some people only need one form of these treatments. Some people need two or a combination, and people may need different things throughout the course of their illness or their life. But these are sort of the cornerstones of what we think about when we look at what helps people get well. And so as an internist and addiction medicine doctor, I really think of this as very similar to diabetes management. So first, there's no cure. And when I'm treating someone with diabetes, my goal is to get their blood sugar normalized and to prevent the acute and chronic complications of untreated diabetes. When I'm treating someone with an opioid use disorder, my goal is very similar. I want to get their toxicology normalized. I want to help them stop using ongoing opioids. And then I want to prevent both the acute and chronic complications of ongoing drug use. So acute complications like death from overdose, and chronic complications like liver disease related to hepatitis C or infections due to ongoing drug use. For all patients, treatment has to be individualized, and we get this in other parts of medicine. So if I have a patient with diabetes, again, who I really think should be on insulin, and they tell me I'm scared of needles, there's no way I'm going to do insulin, but I'm willing to take a different type of medication, I'm not going to not offer them treatment because they didn't accept the one thing that I think is the best form of treatment. I'm going to work with that person to come up with an individualized treatment plan that works for them and for their life and is based on their values and their preferences. And that really is the way we need to begin thinking about addiction as well, empowering patients to be a part of the process of choosing the care that we're using to treat them. Again, medication regimens tend to be very similar, so they include one or all of the following: medication, lifestyle or behavioral changes, regular monitoring and follow-up for complications, and behavioral support. So again, getting back to these sort of three parts of effective treatment, with opioid use disorder in particular, medications are an incredibly effective treatment, more so than any other type of addiction that we take care of. And so it's absolutely important that we talk about those when we think about healthcare providers and healthcare systems' response to this crisis. So with medications, there are three types of medications that are FDA approved to treat opioid use disorder. Methadone is what we call a full agonist, meaning it acts at the opioid receptors in the brain, but it's very slow acting, so people take it once a day. And I think of it as sort of long-acting insulin, again, using the diabetes analogy. Buprenorphine is the next medication we have. It's considered a partial agonist, so it also acts at that receptor in the brain, but you can see that it flattens out. That's called a ceiling effect, which means that at a certain point, no matter how much more you take of it, you won't get more effect. That means it's basically impossible to overdose on buprenorphine, so it's much safer, and people get fewer side effects than they may with methadone. And then the third type of medication or antagonist treatment, or naltrexone, which is also called Vivitrol. You may have heard of that. Opioid agonists, so methadone and buprenorphine, the goal of those, again, is really like insulin. It's really if you think about that cycle where people are needing to use to feel normal, the goal is to get people back to a level where they feel normal. So they're neither intoxicated nor in withdrawal, but they're able to function normally, to not have cravings, and to not be experiencing withdrawal symptoms. So the first important point when we think about treatment is that opioid detox alone is ineffective. We hear a lot of talk about detox, and for some people, detox can be an important first step in stabilization and engaging them in ongoing treatment, but detox alone has a failure rate of almost 100%. So if all we're doing is sending people to short-term detox, we should expect that they will continue to go back to using opioids, that does not treat the underlying chronic disease of opioid use disorder. There's been many, many studies that looked at this. This is a study out of Hopkins where you can see they're looking at the days after detox and the percentage of people who stay abstinent. And by the time you get to a month, only 10% of people are still abstinent, and that's just at 1 month. So when we think about developing treatment systems for people, we really need to think about ongoing long-term care. Many other studies have looked at detox. This one looked at whether you do it inpatient versus outpatient. It really doesn't matter either way. It's ineffective if all someone gets is detox. So detox, again, can be a first step, but it's really not treatment in and of itself. So what is effective treatment? I think we often, you hear people talk about this like we don't have the research yet. And we, in fact, have a tremendous amount of research showing us what can help people stay in recovery and also stay alive. So if there was a cardiology medication where if you took it, you can see in treatment A, this is the number of people who remain in treatment and who are doing well. You can see that 75% of people at the end of 1 year are still doing well. And treatment B, 0% of people are still doing well at 1 year. You think we would have heard about that a lot, right? So this study was done in 2003, and this is looking at maintenance, meaning ongoing treatment with buprenorphine or Suboxone compared to detox. So they took people in an inpatient detox setting. After a week, they randomly assigned them to either get a placebo medication or to get buprenorphine for a year, and both groups got very intensive counseling. In the detox arm, no one stayed in treatment, no one stayed sober, and 20% were dead within 1 year. In the buprenorphine arm, 75% stayed in treatment and 75% were completely abstinent and no one died. So really dramatic differences between these two treatment strategies. There's, literally dozens, if not more, studies that have looked at different types of medication strategies, all showing the same thing. This was a study published in JAMA, which is one of our leading internal medicine journals, that looked at a prolonged detox. So this is using methadone, but they looked at what if you give people 180 days of a very slow medication taper with a lot of counseling. Maybe that will be enough, and compared it to people who got the counseling but also stayed on the medication. And you can see the black line is people at the detox, and basically as soon as they completed their detox, almost everyone relapsed, whereas people who were on medication treatment, as long as they stayed on the medication treatment, they stayed in treatment and not using other opioids. We've got meta-analyses where they look at a number of studies and sort of summarize the results, looking at medication treatment versus non-medication treatment, showing that with medication treatment, in this case methadone, ongoing opioid use is 44% lower than people who are engaged in other types of treatment. We also know that it's the most effective tool we have to keep people alive. This is a study that came out this year comparing people who are in treatment or out of treatment with either methadone or buprenorphine, showing that all-cause mortality was reduced by 2 to 3-fold, and overdose mortality was decreased by 6-fold for people who were in medication treatment versus out of medication treatment. A study looking at our own patients, a mass health study, compared those who are getting non-medication treatments in green to those who are getting medication treatments in blue and red, and found that relapse was 50% decreased amongst those who are on medication treatment, and costs were decreased by $150 to $220 per person per month. Another type of medication we use is extended release naltrexone. Again, that's called Vivitrol. From what we know currently, it's less effective on the broad scale, although for certain selected patient populations it can be really effective, and it's absolutely an important tool in our toolbox. But the studies are limited. So most of the studies have been done in Russia, where medication treatment with methadone or buprenorphine is illegal. And so people have sort of wondered that maybe those aren't as generalizable to our patient population, where we have other types of treatment available. And naltrexone has never been compared head-to-head with either methadone or buprenorphine, although there is an ongoing study that's enrolling currently, so we hopefully will get some more results. This is the one U.S. study that was randomized and published in the New England Journal, and it looked at people who were very carefully selected. So they took people on probation or parole who had to be offered either methadone or buprenorphine and say they didn't want it. They couldn't have had an overdose in the past 3 years, and they were paid up to $800. And even with all of those contingencies, still only 60% received all 6 injections in the study. And that's really the challenge with naltrexone, is it's great for people who are super motivated to continue to get it and highly motivated for sobriety, but the retention rate is very low. So people tend to fall out of treatment. And because they lose their opioid tolerance, if they do relapse after not getting another dose of the extended release naltrexone, their risk of overdose death can be increased dramatically. This study looked at different types of treatment settings, either with naltrexone or without. And in the short-term setting, when people are taking their naltrexone, it definitely improves outcomes in terms of reducing opioid use. But unfortunately, at 6 months, those differences disappeared, basically, between the treatment as usual group and the naltrexone group. So if people are motivated and on therapy, that's great. But again, the retention rates are not as good as they are for other types of medication. And yet, despite all of this, I would hazard a guess that much of what you guys have either seen patients or loved ones or heard about people experience when they navigate the treatment system does not look much like diabetes care. And so why is that? Well, a lot of that, unfortunately, has to do with stigma and has to do with belief as opposed to science. We have a tremendous amount of science showing what works. And yet, in people's heart of hearts, not everyone truly believes this is a disease. For 100 years, our country has punished this as a criminal justice issue or a social issue or a moral issue, and that's a lot of work to undo in a pretty short amount of time. And I think we would be silly to think that as healthcare providers, we haven't been affected by the stigma around us in society and the sort of unconscious lessons that we've gotten. And as a society, many people really do think that folks with substance use disorder should just haul themselves up by their bootstraps as hard as possible, and that it's on them to kind of get better. And that's often what informs the care that people get, rather than what science shows us work or what increases the likelihood that people are going to stay well. And as I mentioned, you will hear people still talk about detox as a treatment for opioid use disorder. Detox alone does nothing to help people stay off of drugs. It may help people get off drugs, but ongoing recovery and remission really requires ongoing treatment. And so the science is clear. Medications for addiction treatment work. This is from our Surgeon General's report. And yet there continues to be tremendous stigma and antipathy towards these medication treatments. I have many patients who are doing very well, who work at Mass General and Harvard and are in incredible, stable, durable recovery, and not a single person in their lives knows that they're on buprenorphine or on methadone because the stigma is so intense. And that only worsens the stigma, because then people's perception of what it looks like to be in recovery on these medications is often limited to a very few number of people who aren't doing very well. We don't hear the stories of the people that are doing tremendously well and living their lives. They're not hanging out on the street corner in front of the clinic, and so they're going about their life doing well. And that stigma is really deadly. It's keeping people out there, it's keeping people using, and it's keeping people dying. The World Health Organization, in fact, their recommendation in terms of treatment for opioid use disorder, they call it the Guidelines for Psychosocially Assisted Pharmacotherapy, really recognizing that for opioid use disorder, medication treatment is a cornerstone of treatment, and psychosocial interventions are absolutely important, but they are layered on top of the medication that first and foremost keeps people alive. And their recommendations are that people should be offered medication and counseling absolutely is an important component of treatment. But if people don't want the whole package, they should still be offered medication as a starting place to get stable, to stay alive, to not continue to use ongoing opioids. And in most cases, treatment is long-term and ongoing. So people generally have to be on medication treatment for years, if not longer. And the goal is really to improve their functional status, the quality of their life, the quality of their health, how they're doing. And I will tell you that no patient, regardless of what illness they have, wants to stay on medications forever. So one of the first questions people will say is, how long do I have to stay on this? We don't have a perfect answer. That varies from person to person, but we can say that at least a year or two as sort of the bare minimum for people to get stabilized. And then some people need longer, and that's okay. What matters is how they're doing, how their health is, and how the quality of their life is. I'm going to skip through some of this just for the sake of time, but I will say that treatment takes time, and early on, people may continue to use a little bit. That is to be expected, and over time, if you stick with people and stick with treatment, they do get better and continue to improve. Treatment is very effective in medical settings, so we often think of people having to go elsewhere to get treatment. Study after study has shown that treatment done in primary care with counseling by the primary care doctor is as effective as specialty treatment. This is a study out of Yale comparing those two things that found no difference when people were sent to specialty treatment versus when they got buprenorphine and counseling in their doctor's office by their physician. And increasingly, we're recognizing that hospitals and emergency rooms can offer this treatment too, and they can do so effectively. The top two studies were at a Boston Medical Center, where they offered people who came into the hospital for other reasons. So they weren't coming in asking for treatment. They were there with their abscess or after an overdose, and they offered them to start medication treatment in the hospital, and found that those folks who started on medication in the hospital were much more likely to continue on in treatment. So in the first group, where there wasn't a control group, actually 82% of people continued on in treatment if they were started in the hospital. They then actually randomized people to either get detox versus staying on medication treatment. And you can see 72% who were started and continued on medication stayed in treatment versus only 12% if they were detoxed and then referred to treatment. A group at Yale took that a step further and said, well, what if we start treatment in the emergency room? So all comers that come to the emergency room, here's this window of opportunity after an overdose or when someone's getting their abscess drained from a complication, where we can actually start treatment in that 6-hour window that we have someone with us. And so they randomly assigned people to either a referral to treatment or getting started on medication and given a 3-day prescription to get them into ongoing care, and found that the group that got started in the emergency room, 78% were still in care 30 days later and were using far fewer opioids, and only about a third were still in care if they got a referral directly to treatment. And so all of this really, I think, highlights the fact that there's this monumental lost opportunity, that individuals with opioid use disorder are interacting with our healthcare system, they're coming into primary care offices, they're showing up in the emergency room, they're getting hospitalized at astonishing rates, as we saw from those first couple slides, and we can start treatment in that moment when they're there with us, and that every encounter with a person dealing with addiction is really a reachable moment to engage with them around their health and their life. And yet the vast majority of doctors feel unprepared to talk to people about substance use disorder. They don't feel prepared to start treatment, and most healthcare systems are not initiating treatment when people are showing up in medical settings. And I will say that we've talked about how life-saving buprenorphine is, and the whole idea with buprenorphine was that doctors were going to be able to prescribe this treatment so that patients could get treatment in the doctor's office, the same place they get the rest of their medical care. And yet, of all physicians across America, only 2.2% have taken the training to be able to prescribe this medication. So if you look at this map, 50% of counties in the US don't have a single prescriber. And if you took all of the access to medication treatment across the country, there's about 1 million people with opioid use disorder who need treatment and aren't able to access it. I'm going to skip forward a little bit, but this quote I think is really important because it gets to that point that I mentioned, that doctors are not immune from societal stigma. I think we wish we were, but we've all been influenced by what we've seen around us, what we've heard around us, and that the mere existence of effective treatment has not been enough to transform the system. That we really have to change our minds and change our attitudes and change our behaviors in order to bring this treatment to patients who need it most. And unfortunately, care too often for people right now looks like the healthcare system blaming them for their medical problems rather than offering patient-centered care the way we do for every other illness. So I'm going to skip forward and just briefly touch on MGH because my colleague Dr. Kane is here and she's going to take over. But we really set out on a journey at the end of 2014 to begin an experiment of what would it look like if we took all of this evidence and actually tried to implement it into our own system so that patients with substance use disorder could get evidence-based care wherever they showed up, whether it was in our emergency room, in our health centers, in the hospital bed dealing with some other medical consequence. And so we started this system of care that we've been working on busily ever since that includes an inpatient team of specialists. So in the same way that if you have a heart attack, you see a cardiologist when you're in the hospital. Now if you come in with an overdose, you can see a team of addiction experts who will come to the bedside. They will engage with the patient, hopefully start treatment right there in the bed that continues after they leave the hospital seamlessly into the community. We've integrated addiction treatment into 7 of our primary care settings now with these teams of addiction champions really empowering doctors and nurses and behavioral health staff to feel like they can and should and will take care of patients with substance use disorder right there where they're providing the rest of that person's medical care. And we've done that by supporting them, going out and sitting with them to talk about cases, and by hiring recovery coaches that you're going to hear a lot more about, who are really an invaluable member of our care team now, people who themselves have lived through and lived with the experience of having a substance use disorder and can provide unmeasurably important support to patients and to teams, providing education for the providers. We started a bridge clinic, which is a low threshold drop-in clinic essentially for people who are either leaving the hospital, leaving the emergency room, or just not thriving in primary care, where patients can show up, they don't need an appointment, they can come as they are, they don't even have to want to stop using. We have coffee and snacks and warm clothes and art supplies and a lot of kindness, and the idea is really just to get people to walk through the door and hopefully to engage with them. And we've studied this. So we studied our addiction consult team and compared patients prospectively who got a consult to match controls who didn't, and found that patients who are seen by our consult team have a lower 30-day readmission rate. They have a decreased addiction severity index score at 30 and 90 days, and they're able to stay sober 25 days out of the month after leaving the hospital compared to only 12 days out of the month when they come into the hospital. In the outpatient setting, our Bridge Clinic has provided 2,586 on-demand visits for 341 patients. About half of those visits are not scheduled, so people literally just showing up, same day, walking in whenever they want. And we found that for people who are seen there after they leave the hospital, their 30-day readmission is only 10%. In the outpatient setting, we now have 38 physicians who are waivered to prescribe buprenorphine in our health centers alone and are caring for 546 patients with opioid use disorder. We now actually are hiring our 10th recovery coach, and you'll hear more about that, and they've touched over 1,000 patients at this point. We continue to try to expand this model and improve. We're working on extending our care in the emergency room. We are now collaborating with pediatrics around adolescent care, with oncology around care for patients with cancer and substance use disorder, with our OB colleagues around caring for the family unit, both women during pregnancy, but also women and babies after delivery. We're continuing to integrate across further primary care practices. We're developing a mentoring program for physicians and NPs who are just beginning to prescribe buprenorphine so that they feel better supported in that process. And we've just started an addiction medicine fellowship, so we're recruiting for 2 fellows for this coming July. So this is a 1-year clinical fellowship for other types of physicians, so emergency room doctors, family doctors, internists, to get 1 year of dedicated addiction specialty training so that they can take the addiction boards and become a specialist themselves. So I'm going to end there, and I think you guys get a little break to grab food, and then Dr. Kane is going to take over and focus really on the recovery coach aspect of our program.
for us to all breathe and reset again. And Dr. Martha Kane is a licensed clinical psychologist who has had numerous positions in various Mass General substance use disorder programs in the ambulatory psychiatry division over the last 2 decades. She currently is the clinical director of the MGH Center for Addiction Medicine and was named the clinical director of the Substance Use Disorders Initiative established in the 2014 strategic plan at Mass General. She has advanced training in cognitive and dialectical behavioral therapy and cognitive behavioral treatment for substance use disorder. She specialized in the treatment of patients with comorbid substance use disorder and mental health issues and their families. She's an instructor in psychology and psychiatry at Harvard Medical School, and we're really pleased to have her. I actually will say that she's been really a fantastic support. I've had numerous conversations with her as we've been trying to build our recovery coaching program here in New Bedford. She was kind enough to talk to me over the last several months about some of the things that they're doing at Mass General, and this will be exciting for us to learn some more and maybe the new directions that they'll be going. So, Dr. Kane, thank you.
Thank you all. This is on, right? It doesn't actually sound like it when you're standing up here. So I'm thrilled to have the opportunity to talk to you about something that is close to my heart, has been a piece of the last couple of years of our work at Mass General to really build up this work with peers and to really come to understand the incredible power that someone who's lived that life, has walked the walk, has in terms of helping someone else start their journey. So I'm going to talk a little bit about the concept of peer-to-peer recovery work, a little bit about what we are doing, and then I'm happy to take some questions from both Sarah's, as much as I can to Sarah's talk. I didn't get to hear the whole thing. It's a long drive down here and a lot of traffic, guys, I just want to say. I'm still shocked. And then anything else you want to know about the Mass General project and whatever other questions come up. So first and foremost, it's extremely important to realize that recovery is not it's not an end point. It's not a stop. It's not a moment. It's a process that goes on for years sometimes, and sometimes gets better and then gets worse and has to be redone. It isn't a stable end point. So often the mistake that folk make is thinking, well, you've had treatment. You've been in treatment for a year, right? You're okay now. Or I don't have to worry about this anymore, right? This is all finished. The truth of the matter is it's never really finished. It's a long piece of work that goes on for a very long time, just like any chronic disease. You're never really done with diabetes. You just have to keep it under control. And that's really what we're dealing with here. Now, in addition to that, recovery is not abstinence. You see this definition here. The word abstinent isn't even in there, right? That's because recovery isn't about not using. Recovery is about quality of life. It's about having a life worth living so that you don't need to do anything to numb out from it. You can just live that life. So it includes health, wellness, self-direction, and reaching and understanding and striving for your own full potential. That's what full recovery is. I ran a program for many years for our youth. Kids 15 to 25 who were substance using and needed to be in recovery, or we thought they did. They never agreed with us about that. But what they would agree about was that their lives weren't going the way they wanted them to. The life was not good. There were lots of problems, and so we could always start there. It sometimes took us 2 or 3 sessions to even get round to the addiction as part of the problem, because we always started with, what do you want your life to be, and how is it different from where you are today? And that's always the question for someone in the recovery who is thinking about recovery is, will it do anything? Will my life be better? That's the hallmark of recovery. So what are the guiding principles of recovery? Since we're going to talk about recovery coaches or peers in recovery, what are we actually talking about? Well, basically recovery happens because people have hope. Hope that things are going to get better. Hope that they can reestablish relationships, get a job, have a life, live in some way that they feel proud of and comfortable with. It's driven by the individual, not by the people around them. It's driven off of what you want, what matters to you, what your values are, what your feelings are, what your experiences are. It comes from internal to you. It is supported by social networks, but it's not determined by social networks. It is highly variable. One of the great fictions that we need to undo is that everybody who goes into recovery starts in detox, goes to rehab, then goes to outpatient therapy, and then they're okay. That is one path to recovery. And if that's what you need, brilliant. But there are so many other ways to get recovery, to make a life worth living, that we have to incorporate and think about as a system trying to help or trying to prevent death. Many sorts of things. We'll talk some more about that. And it is about the whole human being. It's not about just recovery. It's about everything in your life. It's holistic, and everything has to be working if you're going to reduce your risk of relapse. In addition to that, it's grounded in respect for yourself and respect for other people. If you don't respect yourself, you're probably not going to be able to sustain a recovery. So guess what you spend a lot of time doing in the early weeks is figuring out how to even like yourself and start to respect yourself. It's culturally based, culturally influenced very strongly. And it's rooted in both your own strengths, your ties to family or to culture, and your own sense of responsibility to your community. If you don't have a sense of responsibility to community, of connection to other, you're probably going to have a very hard time achieving recovery. Now, if you come from, say, a culture of a native culture, so you've grown up on a reservation, where addiction is a tremendous problem, your sense of family and culture will drive the way you get recovery. Me as a white person, I'm not going to be much help. I'm going to have to listen carefully and think about what is your culture and how does it affect it. If you're a man who comes from an African culture, if you're a man who comes from a Hispanic culture, if you're a woman who's been abused and who's grown up in a culture of trauma and violence, these things are all going to dramatically influence how you ultimately achieve recovery. And that probably makes sense to you if you're thinking, well, right, it's got to be about a quality of life. It's got to connect to who I am in my heart, right? That's where it starts. That all my life experiences feed into that, so that's the only way I'm going to understand and make a recovery. And finally, we get nowhere if we don't pay attention to trauma and to mental health disorders. I don't know if Sarah mentioned it. Again, I apologize, I missed her talk, but mental health comorbidities run in the range of 60 to 70%. So people who show up for substance use care, almost 3/4 of them will have some kind of comorbid mental health condition, and some of those are some of the most very severe conditions we have. So it's extremely important that as we're thinking about systems and thinking about recoveries and thinking about supporting people in recovery, that we're thinking about depression, trauma, anxiety, schizophrenia, et cetera, a whole host of things, bipolar disorder. So let's think about now, if you're sort of following along, then if we were really going to do recovery, we need a whole system of care, right? There's all kinds of things we got to think about here if we're talking about a quality of life. So we talk about this, and think some of you may know John Kelly. This is some of John Kelly's work, the notion of recovery-oriented systems of care. And I love that I'm talking to a community-based group, because honestly, that's the system, right? You guys you come from all the different parts of this town, of this area, of this community. Each of you plays a role. Each of you has a part. It is going to be, if you're able to sort of swing things around here, it will be because all of these parts and pieces start to pull together in a recovery-oriented system of taking care of these folks and helping people get started. So what's it include? A coordinated network of services. Not just do they get their psychotherapy. Honestly, if psychotherapy fixed this, we'd be so far ahead of where we are right now. We've invested way too much time in talk therapy to fix addiction. It's helpful, but definitely not enough. We need legal systems and housing. You don't get recovery if you don't have a house or a roof over your head. It just doesn't really work. We need medical care. We need rapid access to medical care. And we need, every time you touch a place in your town, that somebody there knows something to help you. I recently learned about a guy in Lowell who's a barber, but he's in recovery, So he every Sunday morning opens up his barbershop. I get goose pimples thinking about it. He opens up his barbershop to fathers in recovery who come and they have a fatherhood group in his barbershop. I mean, it's that kind of stuff, right, that we can do. All of us can do this stuff. It's just figuring it out, finding the connections, finding people to help us, and thinking about how peers can help us start to make those connections. It is always person-centered. Again, quality of life. It's about me making my life better. If I need to be in recovery, I'm going to have a reason to be there. I need to know. It's got to be about me. It's not about what you think I need to do. And it's not about what the system thinks I need to do. It's about what I know I need to do. And all of our efforts have to be driven at the individual. It's strengths-based, right? I'm not going to get recovery off all the parts of me that aren't working well. I'm going to have to use everything I've got in my toolbox to pull this off. So it's my strengths, and we take, so often we look at the individual's weakness, and that's all we talk about. Their Achilles heels, their problems. That's where we're focused. That's what we want to talk about. Honestly, let's talk about what they can do. What tools do you have in your toolbox that you can bring out to do this recovery thing? What have you got? Health, wellness, quality of life. I've already mentioned all of those. I won't belabor the point, but I could. That's the heart of this work. And it, again, comprehensive. It covers all aspects of the person's life. And you can have everything else in place and have a couple of things out of place, suddenly lose your job, lose your daytime structure, and lose your source of income, and the bottom drops out of that recovery. And all that happened was you got laid off. That may be all it took. So this is a graph about sort of all the different components that you need to actually manage and treat addiction. Recovery support is a critical piece of that, particularly when you're thinking about sort of recovery-oriented systems of care, so peer-based support. But I wanted to kind of throw this up just to kind of broaden your thinking about all the ways we need to think about this. And all of these are essential to that recovery process. If we don't have these kinds of resources for folks, if folks can't find their way, if I'm illiterate and I can't get a job, I'm not going to sustain a recovery. If I need to be taught how to read, that's going to be maybe my first thing before I ever even try abstinence, I learn how to read. That might be the way in. Anyway, recovery support services, peer-based services are extremely important to this larger process. So let's talk a little bit more about specifically peer-based supports. SAMHSA, our lovely national agency, has defined peer recovery support services as a set of non-clinical, peer-based activities that engage, educate, and support people so that they can make the changes necessary to improve that quality of life. So let's just take a look at that. Engage. Recovery comes because of connection. One of the key elements is I feel connected to someone who I know cares, where I am, that I'm okay, that I show up for care, whatever. Somebody knows and cares about me. So engagement. Education. I need to understand what's wrong with me. I need to understand what I can do with my life, and I need to know that you're listening and working with me to kind of can craft it according to what I need to do. And finally, I need support. I need you to believe that I can do this. Day in, day out, I'm going to slog through dragging those boulders up that hill trying to hold that recovery. I need somebody or some set of somebodies to believe I can do that. Nobody like a peer who's lived through that to be able to, with just the right words and just the right information, to sort of say, I know exactly what you mean. I did it. You can do it. Put on your shoes. Let's go for a run, or whatever. Certainly they're becoming more common. I understand that the town here, I believe it's the town, has now hired 12 for peers in recovery and distributing them in various ways. That's fabulous. At the Mass General, Sarah actually forgets, we've actually got 10 peer recovery people, peers in recovery now who are working with us, mostly in medical settings, including our OB unit. And we have 2 working in our behavioral health unit. So many towns have them. Many towns have peer recovery centers, which are town-owned or owned by an agency. So this is a center run by peers only. super helpful. The list of peer recovery centers for the entire area is on a website. If you Google it, you can find it. And resources are becoming more available. So we now have an Office of Recovery Services for the Bureau of Substance Abuse Services, which is part of the Department of Public Health, and they will train and support people, peers into the recovery process, as well as provide training for supervisors, which we're going to talk about in a minute, kind of the management of this group. There's also money from SAMHSA, federal money that's available. So there are ways you can begin to get this paid for if you're so inspired and want to work at that goal. So what does a peer actually do? Well, first and foremost, they convey hope. They're the ones who hold that hope. On the day when you can't stand it anymore and you just want to give it up, they're the ones who are going to call you on the phone or send you a text and say, don't you dare, meet me for a coffee. Let's talk it out. That they've got that hope. They know you can do it. They believe in you. They really are focused on quality of life issues more than abstinence. So at least for us, the way we've worked with our peers and the way our peers have worked with us, we've come to an understanding that they're going to work on quality of life. They're going to work on getting those warrants cleared if that's what's keeping you out of treatment, or getting an ID if that's what's keeping you from getting your methadone. Believe it or not, that can happen. Or helping you get enough clothing that you can go to the treatment program. Or maybe sometimes they just sit with you around the anguish of, I lost my medicine, they won't give me any more, I'm going to go into acute withdrawal. Yeah, that is what's going to happen. Let's see if we can ride that out somehow without relapsing. It's somebody who just really focuses with you on that thing that's worrying you or that thing that you need to work on. Our peers, I suspect yours as well, are brilliant at getting people into care. When we can't get the door opened, frequently they can. Why? They've been through the system. It's a smallish little network of people who are actually running these treatment programs, and many of the peers have either worked for them or known them. Some of them are in recovery together. However it works, I don't look underneath that. I don't care. How do you know that? I don't care. Don't tell me. Just, can you get my patient to bed? And they're very, very good at that, for at least in our system. They also can hold on to you. So one of the problems with addiction care is it's very siloed, right? I go to my detox, and then I have to go home for 5 days and try to hold a sobriety till I can get into my next treatment level of care. Or maybe I have to wait 2 weeks before I can get into medication treatment. Don't even get me started on the absurdity of all that. Point is, the peer can actually walk with the patient through those times, can hold their hand, can stay with them, maybe even can get it shortened if they can get them into the next level of care faster. So they're very going to hold on to you. They're going to know where you are. Frequently at this hospital we'll say, gee, so-and-so hasn't been showing up for their appointments. Do they have a recovery coach? Can the recovery coach find them? And sometimes the recovery coach can go. They know where they are, or the person will answer their text where they won't talk to us. So they can often hold people through a process when there's all these silos and it's difficult. They can assist with those broader questions, housing, education, employment. Depends a little bit on how you position them, where they are, and what their resources are, but it's quite possible that they could be very helpful, because again, these are as important as abstinence in terms of recovery. They can increase the social connection just because you know where they are. The recovery coach can find you, can have that conversation. They're extremely helpful in holding that connection. Remember, recovery is about connection first. And in general, they can help people not have quite so much trouble with re-offending, with re-violating it or violating it. So every now and then, one of our recovery coaches says, oh, no, we're not blowing off the probation appointment. You're coming with me, I'm taking you there. We're just not gonna, yes, whatever's happened and you want to avoid it, yes, but that won't work. Let's get that done. Or how about we show up instead of blowing off your warrants and getting arrested again, let's just go to court and see what we can do. So they can potentially reduce some of that as well. One of the questions we get all the time is a recovery coach the same thing as a sponsor? And the answer is absolutely not. What's the difference? Well, a sponsor essentially is there to represent a particular way of thinking. AA and NA have a particular code, a particular model, a particular way of understanding recovery. And a sponsor comes from that model and works with the person in that way. A recovery coach is sort of atheistic in a way. Not really, I don't mean that, but I mean they're not wedded to any particular mode of getting recovery. One of the things we say to them all the time is there are thousands of roads to Rome. Find the one your patient is on and get on it with them. It doesn't matter what the right pathway is. So they're just kind of going to support you in whatever quality of life effort you're making, whatever work you're doing. They're not the same thing as a sponsor. So what kinds of things do they tend to do? Overall, and based on sort of several studies across the country, their work tends to land in one of these 4 categories, and probably more than one, depending on the setting. They're certainly empathic and caring, and that's number 1, connection and understanding. But they have a leg up on the rest of us in terms of really understanding what this life is like, or what recovery process is like. They certainly are a wealth of information. They educate. You heard me say before, our recovery coaches have helped us come to understand, and then there are many things that in that sentence, they've helped us a ton. They are also helpful to the patients in terms of sharing information and understanding how the world works and understanding how to make things work and be successful. They provide social support. I think I've kind of made that point. They often find the patient, hunt the patient down, create that connection, help the patient. And then finally, they're very actively supporting. So they may drive you to the probation appointment. They may drive you to, not drive you, we don't actually let them drive, but meet you at court, meet you at the coffee shop and walk with you to your therapy appointment, go with you to a medical appointment because you're absolutely terrified of the cancer diagnosis and you can't even listen while you're in the room and you've got nobody else to go with you. Things like that. They can absolutely be specifically actively engaged. So they tend to kind of do one of or more than one of these 4 types of services. They coach or mentor, helping you set goals, helping you meet your challenges, being supportive without dictating to you how you're going to do your recovery, giving you a role model though, and providing some hope. Or they can work as connectors, which I've mentioned. They help you link into, they can get that bed for you, they can help you find the resource you need, they can help you access housing or whatever it is, and then support you in that effort. They often run recovery groups. I think every one of our recovery coaches, except maybe the newest one, are actually running peer support groups. These are not clinical groups. This is where we come together. It probably looks if you've been thinking about a little bit more like an AA meeting, but it's not AA. So it's really about talking through what's going on, getting ideas, coming up with resources, all the other things, but they'll do it in groups. At the hospital in the Bridge Clinic, which Sarah referred to, we have 3. One is an art therapy group. And how that works is you come in, pick up your art supplies, sit down and start talking about what's on your mind. And so the facilitator is in recovery herself. She essentially uses, you do this too, right? Get your hands busy and your mouth starts going. And you start talking about what you're thinking about or worried about. So she uses it that way. We also have a peer-led group that works on understanding your medication and how to take it and understanding where you kind of can get off track with that. And that's co-facilitated by a pharmacist, but it's essentially peer-led. So lots of different ideas, things to think about, ways to do it, depending on the setting where the peer is. These are super helpful groups. They're typically not billable, so this is not a way to support it, but they absolutely are invaluable. And then peers are in the busy business of actually building communities. And I was talking a minute ago about these peer recovery centers, which are peer-run centers that provide a wealth of support, ideas, information. I think there are 12 in the greater metro area. I would hesitate to be held accountable to that number. And they're all basically owned by a parent company and then staffed by peers. So extremely important and valuable resource. If there happens to be one close by, you should find out about it, and it's a marvelous resource. If you don't have one, how about starting one? It's a great idea. They're also extremely adaptable, as you're kind of noticing. They can work across all the different degrees of readiness. So somebody who's ready to go to detox is one sort of person who needs one kind of service. But what if your attitude is absolutely no way? I am not going to detox. I don't need it. I just have pain. And I'm tired of people not listening to me about that. Okay, that's a person who's not really ready to look at their relationship to the opioids. Fine, a recovery coach can still potentially be very, very helpful. They can adapt across multiple pathways. We sort of talked about that. It depends a little bit on the coach and the setting. They could certainly do spiritual or religious. Many religious institutions are now hiring peers. You might want to check into your churches around here and see if any of them are involved in that. Medical institutions such as ours all over the city, primary care and hospitals are all getting involved. Cultural institutions, the Irish Immigrant Society in Boston, places like that are beginning to think about how to use peers in recovery. So, multiple settings. I think I've mentioned most of those already. So what are the principles of the recovery coach or the peer recovery process? Basically, recovery is the center of it, but we come at it in from multiple different directions, all of these being critical, and you can enter the process from any one of these. You don't have to, in fact, recovery might and probably isn't the first thing you're going to work on itself. It's participatory. We don't demand, no peer is, nobody is forced to work with a peer recovery person or support person. You get to choose if you want to. I would say to the coach, I said, just stand still and be the beautiful flower that the bee wants to land on. Just wait. They're going to come. The butterfly's going to land. They may take off again, but they'll land again. Let them negotiate that so that they become participants. It's got to be inclusive. It's got to be culturally relevant. Depending on what the cultures are that sort of make up your community, it might be important to have peers who come from those different cultures so that you understand that people are getting good, solid support. It's authentic, it's mutual, it's not psychotherapeutic at all. It's two people working together towards a common goal. And in the process, the peers will begin to develop leadership skills, will begin to develop the capacity for organization, and you want to support and pursue and help them make careers out of this. We want them to stay at the work. We have now a recovery coach manager who began as a recovery coach and has worked his way up, gotten certified. He's now managing all of ours. I've just hired another guy who I think in maybe 2 or 3 years is going to be ready to take on a management role. As he is sharp and on top of it and already starting to say to me, you know, we could do this better if we did it this way. Okay, well, let's think on that. It's important that the recovery identity is at the core of this, that this is a shared disease and a shared process of working towards something, a shared experience. The focus is on supporting recovery, though it isn't always on achieving abstinence. Remember, recovery with that larger definition. It's patient-centered and always focused on strengths in the person, not that they have a weakness or a problem, but that they have many strengths, and that those strengths will lead them where they need to go, and that they become empowered to take advantage of all their strengths to work around those problems that they have. There are very specific ethics associated with this role. It's one of the reasons why peers need to be trained and certified. There are things that they need to think about. They're going to find themselves in situations that both trigger them because they are in recovery themselves and will remind them, places where they've got soft spots, where they can forget that they're on this side of the addiction and not that side. We had a peer recently who got very, very upset because a patient was denied medicine, denied her Suboxone. That's how she saw it. Got very, very upset, really lost her composure. And our peer got very upset right along with her, like in a parallel way. And we had to work with the peer to remind her that there were two things happening here, that she was separate from this individual's response, and the individual's response was really out of bounds with, in fact, blocked her from achieving her medicine, which probably could have been done if she handled it differently. So the peer had to be really coached around that and to remind that there's a boundary there. Very tricky stuff for them and very complicated, and they're very passionate about what they do, so it can be difficult. Which leads me to what we're going to talk about in a minute, which is the management of. So peer-to-peer training is absolutely essential. They need to do the training. The Office of the Bureau of Substance Abuse Services here in town offers very nice trainings, and they need, here in town in Boston, they need to continue to be engaged in the process of learning about how to be a peer and how to manage their own needs. Of course, the peer recovery is actually not new. It roots itself, comes out of NA and AA, which have been around for more than 50 years now, with absolutely clear evidence that if you get involved in AA or NA, your likelihood of sustaining long-term recovery is dramatically increased. It doesn't work for everybody, but when it does work, people are really much more capable of sustaining long-term recoveries. And then the Accountable Care Act hit us, and substance use treatment became mandated, and we also got integrated care, so that we began to see an integration of behavioral health and medical care, which gives us a golden opportunity to try to think about how to engage peers in that process. And I think about 2011, we started seeing recovery-oriented systems of care conversations, people really looking at how whole communities can come together to create systems that hold and help people through the multiple pathways. And in 2013, the Office of National Drug Control Policy made recovery-oriented work one of their top priorities. So we're really getting, very recently, a very significant increase in the support and the importance of it. There's really only limited evidence to date, a few studies so far. It has a tremendous amount of face validity, as in it totally makes sense, and anybody who's ever worked as a peer or worked in peer recovery, you can see the difference that it makes. There's we're still working on developing and really testing that and understanding for whom and in what kinds of settings. There's a study going on we're just about to get funded a study at Mass General to work on that. John Kelly's got a big study in our Center for Addiction Medicine. So really trying to kind of work at this notion. Basically, the evidence at this point suggests that peer-based interventions have at least a salutary effect and a positive contribution, and we're still trying to get clear. So there are lots of future directions we need to work on and things we need to figure out still. But I think at the moment, this is something that we know has enough potential to go ahead and push forward. So this is how we set it up at the General. I understand this is just us. This is a tertiary care medical center with several health centers and an emergency room and so on and so forth. But this is what we ended up doing. And Sarah kind of alluded to this. We essentially have our inpatient team. We have our outpatient teams in all of our health centers and primary care practices, or many of them. We have and created many, many linkages to our communities of care, all sorts of things, legal services and housing services and substance abuse services and methadone programs. And so we've created primary referral relationships so we have places to send people when people need it. The Bridge Clinic is sitting there kind of in between in and outpatient. That's obviously where, as Sarah mentioned, people can just drop in or walk in. It's generally for people who are too unstable to take advantage of traditional outpatient care. They're not going to show up for appointments. They're too ill. They can't organize themselves. They're resistant to it. They're not ready to stop using. Whatever the problem is, they're very unstable. And so they can just walk in or drop into the Bridge Clinic. But we think about our recovery coaches as essentially linking all of these systems together. So somebody has a recovery coach assigned basically out of their primary care setting. Why primary care instead of behavioral health? Because a primary care doctor never fires you. They never give up on you. Doesn't matter how many times you blow it. Doesn't matter how high your A1C gets. They just say, come on back, let's try again, all right? So we figured that's the attitude we wanted for addiction too. Doesn't matter how many times you relapse. Don't care if it's getting worse, just keep coming back. Come back, we'll figure something else out. So we put them in our recovery, in our primary care practices mostly. And so then they, from that position, can reach into the inpatient, can reach into the Bridge Clinic, can reach to the community if they need to. They're there essentially to kind of connect all of these variety of services and systems together. And that has worked out really well. I think we're very, very excited about that and excited to study that. So peer-to-peer connections, engagement, blah, blah. Oh, warm handoffs, follow up forever, and they educate us constantly. So Sarah mentioned some of this. That's old. We have 10 as of yesterday. The thing I want to highlight here is qualitatively we have done a study. Our patients are reporting that the experience is better, experience in the inpatient side or the primary care setting. Their medical experience is better when they've got the recovery coach support. In addition to that, they find it easier to get into social or other types of agencies, which of course we agree with. It looks easier to us too. And they feel they've got that support that links them across all those systems. What we've learned with this is that when you've got a recovery coach, there's a 10% reduction in inpatient admissions. Now, y'all know what an inpatient admission costs, right? 10% reduction is pretty significant cut. And so we're very excited to pursue and understand that better. But more important to me and more exciting to me, because my side of this is the outpatient side, is they show up more for their primary care appointments, and they show up more and have more mental health visits once they've got a recovery coach. So it means people are actually getting to care by virtue of having this additional support. We do have a recovery coach program manager. As I said, he is actually certified as both a coach and a manager. And he's also actually certified by DMH as a peer counselor there as well, which turns out to be very important because this is such a dual disorder. And he provides an hour of individual supervision every week, 2 hours of group supervision every week. You're getting this theme that they need to spend some time working together and sort of stabilizing and being effective. And then they work in these particular domains: advocacy, mentoring, recovery, wellness, and ethical responsibility. So these are some of their focal points where they really have to be educated and kind of keep these ideas forefront in their minds. He also uses a lot of group supervision where they're sort of utilizing the wisdom in the room. He puts all of them together and they brainstorm and problem solve out what it's like. So a lot of talking and communication, and that really has helped a lot. Each recovery coach has their own area of expertise, which they're challenged to develop and build and share with their colleagues, so that allows them to build careers. And then they also are all getting their own certifications, which is extremely important. That keeps them thinking about professionally working and developing their own skill sets. And then, of course, we not only encourage, we pay for them to go to these trainings all year long. So I'm going to wrap it up here. I don't know what kinds of questions you might have or thoughts, or I know it's long and you're probably here far later than you expected to. Yeah.
So you mentioned the importance of stable housing.
Yeah.
What has the experience been of using recovery coaches in homeless communities?
So we have a recovery coach who works for Healthcare for the Homeless, and he actually is assigned to the street outreach team. So he only works with people living on the street or those who've been on the street recently and are just recently housed. It is an incredibly important role. He actually runs a group for folk who are Healthcare for the Homeless patients every Wednesday morning or Thursday morning. It's a 3-hour group. You can come and stay as long as you want. You can walk in and leave, whatever. What he's found is that everybody who's entered the group was actively substance using at the time, and within about 12 to 15 weeks has basically stopped using. So what happens in this group? Some kind of magic, right? Basically, the guys all talk each other out of using. They talk each other into some kind of abstinent recovery, and we are lucky to have him. He's brilliant, ex-military guy who just does great work, but he sort of facilitates that conversation, and they all essentially talk themselves into recovery. I'll say kids will do that too. You put a bunch of kids who are drug using together in a room and kind of propose the concept, they'll talk each other. They can see why someone else needs to stop. That doesn't mean they can see why they need to stop, but they talk each other into recovery. Anyway, so I think it's brilliant. I think it absolutely works. I think it's a minimum support you can offer to someone who is homeless and having to try to do this without a roof over their head, which is a tremendous challenge. The other thing I will say about our recovery coach in that setting is he is all about harm reduction. The guy, I don't think he's got a judgmental bone in his body. He just doesn't, and he never sees the glass as half empty. He's always got a positive take with you. So the right person, right setting can be a critical support, I think, for some people who are just dramatically affected and suffering tremendous stress. Other questions? Yeah.
Are there e-services available like for teens, that are the leads, that they're in recovery?
There are, I don't know about teens, but yes, I suspect they could be. Teens in recovery they need more kinds of supervision, because they're kids and their frontal lobes are not done developing yet, but a little help with that. But we have actually in the ARMS program, which is our program for youth and young adults, we have several kids who've graduated and come back in a volunteer peer support kind of way. We haven't paid them. The peer recovery specialist they actually have is a little bit older, but I think it's a brilliant idea. I think absolutely teen-based programs should and probably do consider it, and I'm just a little bit behind the times. I know we hired another great coach. We stole him from Bridge Over Troubled Waters, where he was working with kids, but he's not a kid. He's probably my age. But he has a way to, he apparently relates well to everybody. So it's a great idea. You could certainly look into it. And the only caveat would be that you provide enough oversight and guidance in a positive way to help them make right choices. And there's a tremendous amount of decision-making and judgment required to be a good recovery coach. So other than that, yeah.
Can you talk about the Columbus project?
Yeah. You're not going to like this answer. Basically, the hospital is paying for the recovery coaches right now. That's an artifact of the fact that our billing and our overhead and billing structures are such that the amount that the Department of Public Health would pay us to hire a recovery coach, we would actually spend more than to cover the services that would be required to kind of manage the grant and whatnot. So it's an artifact of where we are and how the hospital's sort of structured. Most community agencies are using contracts from the Bureau of Substance Abuse Services to cover these expenses and are doing so successfully. So I think that's absolutely an avenue to look for. There are grants. There are also some interested parties looking at research where if you were willing to engage in the research process, the Arnold Foundation, for example, where I think we're going to seal the deal on a grant from them to hire a recovery coach and then study the implementation of that. So there are ways to do it. It's not super easy. No health insurer is paying for this yet, but that doesn't mean we should give up trying. Stay at their door. I will say we have had a pilot with Beacon where they for 2 years did fund a recovery coach for us, and we're crunching the numbers with them now to see if it was worth their time and money. And I think that's really a direction we can all go, is to try to get the payers to think about this as a viable service. In addition to that, moving to the accountable care model, to the integrated care and risk contracting in the healthcare industry is going to force us to look at ways that don't cost as much to get better care. And I think in that context, we're not having to bill face-to-face contact for doctors' time. We will have more flexibility and the ability to look at the effectiveness of that kind of smallish salary in contrast to what a physician would get and the outcomes associated with that. So complicated, we're in process. Get on the train, we'll get it done, but it's going to be a little while and a lot of work. Somebody else? Yeah.
The 1115 waiver with medical, is that possibly?
Possibly. We'll see. Yeah, we'll see. Yeah. Yeah. I'm hopeful. I don't know. You know, I've been around a little too long to trust anything's going to work immediately or quickly. No, that's entirely the hope, yes. We'll see what Washington does and all the rest. Yeah?
It's actually in our 1115 waiver already.
Good.
So the next round of MCE contracts, the mandated service recovery coaches, the rates already been set by the Commonwealth.
Oh, that's such good news. I didn't know that. Thank you for sharing that. Great news. Anybody else? Some of you look a little dubious. You wouldn't like to ask a question? No? Well, thank you all very much.
So I'd like to ask Patrick Carney to come up and say a few words to close out our program, and really thank you, Dr. Kane, for sharing your wisdom and what you're doing, and really it's great work. Thank you.
Thank you all for being here tonight to be part of this great effort. I've oftentimes heard professionals in addiction recovery say, no family goes untouched. And I'm sure many of you have experienced this. I've also heard that addiction is a family disease. It's not just the addicted family member. The whole family suffers from the addiction. So the work we're all engaged in is so important. I want to thank everybody for being part of this program tonight. And I'm sure we'll be seeing more of this in our community. I want to thank Mayor Mitchell for his opening remarks and for his leadership, Chief of Police for all his work in this area. The doctors from Mass General, thank you so much for the great presentations tonight. Fabulous. I want to thank the task force that is working on this. There's just so many people. Dr. Rocha, thank you for all of your efforts in our community. It's a giant effort we have in front of us, but we have to do it. And I want to thank you all for being part of it. And thanks for being here, and I hope I see you at more of these events. Thank you.